Hello, everybody, and welcome back. Today we are covering NBME 27. We finished yesterday on 110 with our discussion of polycystic ovarian syndrome, and now we're going to move on to 111. Before we get started, these videos take a lot of time. I estimate I spent over 100 hours making these, but I'm doing it for you because I want you to succeed. So please like and subscribe if you're trying to increase your scores in the NBMEs, and let's get started. A 68-year-old woman undergoes an emergent colectomy for ischemic colitis. Her intraoperative course is complicated by persistent hypotension, requiring vasopressors. On postoperative day 2, her serum creatinine has risen from 0.9 to 4.2. Urine analysis shows a muddy brown cast. All right, this question is over as far as I'm concerned. The answer has to be acute tubular necrosis. And you might be asking, okay, why is the muddy brown cast so specific for ATN? Well, let's break this down. The muddy brown casts are the necrotic tubular epithelial cells, plus a little bit of that TAM-Horsfall protein. And these form specifically in the setting of acute tubular injury, especially the ischemic or nephrotoxic ATN. And so the mechanism in ATN, especially from ischemia and toxins, is that the proximal tubule and the cells in the proximal tubule in the thick ascending limb suffer from a hypoxic injury and they die. And what happens to them after they die? Well, they slough off into the tubular lumen. Okay, so that's the first step. Secondly, in the pathophys, you get the debris, the TAM-Horsfall protein. And that's just a normal protein, by the way, that's secreted by the tubular cells, and it acts like glue. It traps the dead epithelial cells and it forms a granular cast inside the tubule. Okay, so that cast formation by the TAM-Horsfall protein and the debris is the second part of the pathophys. And then the appearance. So these casts are coarse, they're pigmented, and they're dark, they're muddy brown. And that's why we describe them as that granular, dirty appearance, kind of like mud. And the reason why this is so high yield is the specificity. They virtually only occur in acute tubular necrosis. They don't occur in prerenal, aka or glomerulonephritis or interstitial nephritis. Also, the location is important because their formation requires functioning tubular systems. And so if the damage is intrarenal, especially tubular, then the cast will form. But the prerenal states won't form casts because the tubules aren't damaged. So if you see the muddy brown cast like I did in this question, the diagnosis is almost certainly ATN. Another kind of lower yield tip is you probably heard of that iron sodium. That's going to be greater than 2% because the tubules can't reabsorb the sodium. The urine osmolality is also going to be probably less than 350. That is to say pretty dilute. And your BUN creatinine ratio is likely going to be less than 15:1. The final takeaway is that muddy brown casts are dead giveaways for acute tubular necrosis. It also helps to know that this is the cause of direct tubular injury, either from ischemia or nephrotoxins. Okay, there we go. First question. Let's move on to the next topic you need to know by the time you finish NBME 27. By the way, all these questions are my own, but they cover the content and the topics that are required to get a good score on the NBMEs. Okay, for the next one, I like to call this triggering trypsin. So trypsinogen is activated by enterokinase, specifically enteropeptidase, in the duodenum. And then trypsin goes and activates other pancreatic zymogens, including itself. So here's our practice question. We have a 29-year-old man participating in research study that examines digestion. After consuming a protein-rich meal, samples from his small intestine are analyzed. Activation of trypsinogen is observed shortly after the food enters the duodenum. Which of the following is most directly responsible for the enzymatic activation? The answer is enteropeptidase. And the acinar cells are the functional units of the exocrine pancreas. They produce and secrete digestive enzymes. So they secrete an active trypsinogen into the pancreatic duct, and it will go into the duodenum. That's the first step of the pathophys. Enterokinase is going to cleave that trypsinogen, so now it's going to be active trypsin. And then trypsin activates more trypsinogen. It'll go and activate more. It's the circle of life. And then it'll also activate other proenzymes like prolastase, chymotrypsinogen, procarboxypeptidase. So the third step is the activation, what trypsin does after it's activated. Kind of like Chris Pratt in Passenger. He just goes and activates other sleepers. And then the fourth thing is the enzymes digest dietary proteins and absorbable peptidases and amino acids. So the big picture here is that trypsinogen is inactive and it's only activated in the duodenum. Enterokinase is a brush border enzyme that starts the protease cascade. And premature trypsin activation in the pancreas can cause pancreatitis. But without enterokinase, the protein malabsorption, steatorrhea, and failure to thrive can occur. So we need enterokinase. We need it. So that brings us to our question, which is responsible enteropeptidase. So the pancreas ships out this stuff that is incredibly potent and powerful, but it ships it out in its inactive form. And once trypsinogen is activated into trypsin, then it can activate every other major protease in your gut. So the real MVP of that kind of scenario is enterokinase, not trypsin or secretin. Now, CCK stimulates pancreatic enzyme secretion, not activation. Secretin stimulates bicarbonate secretion, and trypsin has the autocatalysis only after the initial cleavage step by enterokinase. And gastrin has increased HCl via the parietal cells relevant to the gastric phase. If you think that I explained that well, please like and subscribe. If not, give me a comment on how I can improve. Next question, 113. Again, just trying to help you score well. I even bought this green screen for you guys. All right, 38-year-old woman with a family history of early onset breast and brain cancers is found to carry the TP53 gene mutation. Functional studies reveal that the mutant protein binds DNA less efficiently, particularly near the Tata box, promoter regions of the cell cycle regulatory genes. What is the most likely downstream effect of that mutation? Now, let's talk about this before we approach this question. P53, you've heard of it a lot. It's a tumor suppressor gene. It's like a security guard for your DNA. It'll stop all the bad cells from dividing when the DNA is damaged, and it does this by turning on the stop genes like P21. All right, it's the security guard. Now, what exactly does it do? It finds the promoter, which is like the start site of certain genes, and it helps the RNA polymerase bind there so that the gene can be copied or transcribed. So it helps the RNA polymerase bind there. And so if P53 is broken, then that security guard is dead, let's say. The genes don't get turned on, and so the cell division just keeps on going, and you have cancer risk. And this is like a landing pad for RNA polymerase. So here's the Tata box, and there's the gene. It's the landing pad. And RNA polymerase, it just can't stick well if you don't have that healthy Tata box. And so if the box is damaged, or if P53 can't help to guide it, then you have less gene transcription. And so you might ask, what would a mutation be doing there? So in the patient in our practice question, the P53 is mutated. I think it was like one of the amino acids gets changed. Well, that small change is totally going to throw off the groove. You threw off my groove of the P53 shape. And now it can't bind to the DNA very well, and it can't help the RNA polymerase attach. All right, so we can't attach, then what's going to happen? The transcription is going to go down, right? The transcription of the important genes that we mentioned, like this guy, I'm important, not going to happen. And so the cancer is just going to keep growing and growing and growing. And so just a test question tip here. On test day, if they mention P350 mutation, Tata box, or transcription being messed up, then the answer is probably going to be a decreased binding of RNA polymerase. And that's the reason why it's decreased binding of RNA polymerase 2. And you can also pause and see all these reasons why the other answers are incorrect. But for you eager learners in the back, I want to just clear up any miscommunication about DNA polymerase versus RNA polymerase. Now, DNA polymerase's main job is to copy DNA to DNA. It's replication. And you know that because it has DNA in its name. Now, RNA polymerase has a different job. RNA polymerase copies DNA to RNA. Is that called replication? No. That is called transcription. We're transcribing it. It's like you're changing its language. And DNA polymerase is used in DNA replication, but RNA polymerase is used in gene transcription. Very important. Okay, cool beans. Well, how are they similar? Well, as you can see, they're both reading the DNA template. They're just doing different things with it. The DNA polymerase now makes a new DNA strand. The RNA polymerase makes an RNA strand. And that's the reason why they have the different names. And now there's one more distinction that's important for step one, and that is that DNA polymerase, this guy right here, it will need a primer. It needs a free 3' OH group. However, RNA polymerase, it don't need that. We're good. We can start from scratch. RNA polymerase also does not have error checking. It just goes for it. There's no proofreading. Error checking does occur in the 3' to 5'. You read up, write down for DNA polymerase. And so I would say DNA polymerase is just a little bit more robust. It's got proofreading and it needs primers. RNA doesn't. Another similarity is they both work in the nucleus, but the DNA polymerase works in the nucleus during the S phase of the cell cycle. And then the last thing is their types in eukaryotes. And what do I mean by that? All I mean is that there are different types of DNA polymerase and different types of RNA polymerase that are found in eukaryotic cells, which are just, human cells. And so you don't need to go too much into the weeds here. There are enzymes that your body uses to copy a DNA before cell division. One of them is the DNA pol alpha, and that starts the job. It lays down the RNA primer. Then you have, the lagging strand synthesis, you have the leading strand synthesis, and others. But just know that there are different types. And then for RNA polymerase, there's RNA pol 1, that makes rRNA, that's ribosomal RNA. And then there's pol 2 that makes mRNA, the messenger. And then your third type as well. And that makes tRNA. Cool beans. So hopefully now it's clear that all of our Tata box nonsense is going to change it so we have less transcription. And if there's less transcription, we're dealing with RNA because we need that RNA for our polymerase type 2 so that we can have messenger RNA, which does the job of P23. And that, my friends, is how it all works. Okay, there's 113. Let's move on. We're on a roll here, folks. Now, first things first for this question, you can answer it on your own if you want. I just want to teach you guys a little bit about the cillins. Ampicillin, amoxicillin, piperacillin, and any other cillin that you might see on test day. Now, amoxicillin and ampicillin, these guys are aminopenicillins. They're aminopenicillins. And aminopenicillins are extended spectrum penicillins that contain a beta-lactam ring. They've got a ring around them. And these guys will bind, and penicillin binding proteins are a group of essential enzymes that are found in bacteria that play a role in the synthesis and maintenance of the bacterial cell wall. So they bind that, and it will halt the peptidoglycan wall synthesis. Aminopenicillins are gram-positive. Aminopenicillins have activity against gram-positive, like staph, and they also have activity against gram-negative. They are broad-spectrum antibiotics. Now, amoxicillin has oral bioavailability, and these two, your aminopenicillins, treat streptococcal pharyngitis, strep throat. And they can also help out these two, the aminopenicillins, with treating pneumonia, strep pneumonia, Haemophilus influenza. There's another thing to know about amoxicillin, and that is that it's good for H. pylori. It's part of the triple therapy, and it can help treat Lyme disease. And we mentioned it has oral bioavailability, but it can also be administered through IV. And I mentioned the beta-lactam stuff, right? Well, that's important because beta-lactamase producing strains of Enterococcus are resistant to ampicillin. So there's drug resistance there. Now, piperacillin and tecarcillin, these are extended spectrum penicillins, and they treat anaerobic infections. So there you can think of like a Pseudomonas infection. Broad strokes, just wanted to tell you guys what these penicillins do, especially amoxicillin, just because I think it's important for step one, super high yield. And also this is what I wish somebody would have taught me. Now let's talk about macrolides real quickly. So with macrolides, we're thinking of erythromycin, azithromycin, clarithromycin, oxamycin. Now these guys bind to your 50S. That's the 50S ribosomal subunit, and they prevent ribosomal translocation, and they inhibit protein synthesis. They're almost all bacteriostatic except for fidaxomicin, and that's bactericidal. And I like to remember that one because it starts with F for reasons. I don't know, it just helps me. And these guys can be helpful in chronic lung diseases like COPD, cystic fibrosis, and bronchiectasis. They can also treat walking pneumonia, so mycoplasma pneumonia. So super cool what they can do. The last one that you might be tested on is your Bordella pertussis. They're used for treatment and also prophylaxis for Bordella pertussis if you have close contacts, as well as Bartonella infections. That's the cat scratch fever. It's used to treat that as well. And it can be used in combination with atovaquone to treat the Babesia infection. Whole host of other things like the antitoxin on Corynebacterium diphtheria infections, as well as your MAC infections. But yeah, it can prevent your MAC infections for when your CD4 count is less than 50. Okay, so that we've covered. And then the last thing I want to cover before explaining this question is your fluoroquinolones. Now, these guys are used in gram-negative bacteria infections, and their role is that they inhibit bacteria topoisomerase. So there you think of DNA gyrase. And so I mentioned they can treat gram-negative UTIs like E. coli, and they can treat anthrax as well, and community-acquired pneumonia, walking pneumonia, like mycoplasma pneumonia. For that, you give levofloxacin and moxifloxacin. And the atypical walking pneumonias like Legionella, again, that's going to be levofloxacin and moxifloxacin. And what's really particular about these guys that you might see on test day is that some of the cations, and here we're thinking of calcium, iron, magnesium, will cause decreased absorption. There are also several risks with fluoroquinolone, like the risk of prolonged QT intervals is a very common one that you'll see. Also GI upset, so nausea, vomiting, diarrhea. And then what's really particular, and you're almost guaranteed to see this one, they just love asking about this, have a risk of tendon and cartilage damage in the elderly, especially if they use chronic steroids. And this is not recommended for children, and it's teratogenic. Why is it teratogenic? Think about it. We mentioned the tendons and the cartilage. That's the reason why it'll damage them. Okay, I think we got enough background to be able to answer this question. And hopefully you guys were able to skip to the questions you want. Always love it if you watch it all, though. I think it's a good thing to put on when you're going to bed. Get that subconscious listening to this stuff. But yeah, 62-year-old man, popping his right calf. Oh, he's got treatment for prostatitis. What do we say that treatment would be? Probably one of our fluoroquinolones like levofloxacin. Avid walker, what contributed to it? Definitely fluoroquinolones, because it has that risk of the tendon rupturing. Here are the trap answers. Doxy. For that one, you think of photosensitivity. TMP would be folate antagonism. And the amoxicillin we talked about, maybe think of diarrheas and allergies, not tendon associations there, nothing there. And azithromycin, QT prolongation, and GI motility, but not the tendons. Okay, so we did a deep dive on that, but that's just because I think the only way to answer these questions is to learn about all the different bacteria and all the different antibiotics. Now, for this particular question, the things to look out for on test day would be a long distance runner, that's going to tell us that he's got a tendon load. Achilles tendon rupture, because that's very common to rupture. And that almost cues you in automatically to fluoroquinolones. And also antibiotic for upper respiratory infections. Fluoroquinolones are often used for that. And so that all those things should point you in the direction of answering this question correctly. So we're thinking ciprofloxacin and levofloxacin for Achilles or tendinopathy ruptures. Also, the elderly is a giveaway there too. He's greater than 60. We mentioned this isn't for the kids, and the mechanism isn't fully known, but we just know that it decreases your collagen synthesis, increases your matrix metalloproteinase activity, and causes collagen breakdown. And all that happens by inhibiting bacterial DNA gyrase and topoisomerase 4. If you guys like that in-depth breakdown, let me know and I'll make more like it. Otherwise, I'll be a lot more brief. Just let me know in the comments. Next question, a 58-year-old woman is intubated for respiratory failure due to pneumonia. Her arterial blood gas reveals pH of 7.25. You want to lower the PaCO2? What should you do? So basically, how do we adjust a ventilator to fix hypercapnia? What we do is CO2 removal through ventilation, not oxygenation. And there's some formulas that are important here. Your minute ventilation is your tidal volume times your respiratory rate. And we know here that our PaCO2 is too high, and so that's a ventilation problem. And so we should increase the respiratory rate or the tidal volume, which would have the effect of decreasing your PaCO2. And they're trying to throw in some distractors like your PEEP and FiO2. Well, that's all you'll note oxygen stuff. That's oxygenation, not ventilation. So it doesn't have to throw out the oxygen if you can't get rid of the CO2. So this question is getting at the heart of oxygenation versus ventilation. And we know there's hypercapnia, and that's causing our respiratory acidosis, 7.25. There's minute ventilation, which is the respiratory rate times the tidal volume. If you increase either of those, then you get more CO2 that's blown off. So we're thinking of something that involves respiratory rate or the tidal volume. But all of that PEEP stuff and FiO2, that's oxygen stuff. We don't need that. We need ventilation. We need the movement of air in and out of the lungs. And to blow off the CO2, you need more fresh air that reaches the alveoli. And that's controlled by tidal volume, how much you breathe, and respiratory rate, how often you breathe. Together, they make up minute ventilation. And so your patient is on a ventilator. In your head, separate the two things, oxygenation and ventilation. Ventilation is about getting CO2 out, and that depends on the minute ventilation, which is your tidal volume and your respiratory rate. And so the answer to this question is going to be one of those two variables, which together comprise your minute ventilation. All right, there's 115. Now let's go on to 116. Right inside of 6. We have a 52-year-old man presenting with episodes of facial flushing, non-bloody diarrhea, and wheezing over the past several months. His symptoms worsen with alcohol. Physical exam shows a grade 2 out of 6 holosystolic murmur at the lower left sternal border. He shows centrally located pulmonary mass. Which of the following is most likely? Now, let's break down a couple of these terms so that they become super pathognomonic for certain conditions on test day. First of all, the urine 5-HIAA, that's 5-hydroxyindoleacetic acid. It's the main breakdown product of, drumroll please, serotonin. And serotonin is broken down by MAO, and it turns into 5-HIAA and is excreted in the urine. And so if the urine has a super high amount of that, that means that there's too much serotonin being made in the body. And that is commonly seen in a carcinoid syndrome, because that's a serotonin secreting tumor is called a carcinoid tumor. So serotonin, carcinoid. And so I would just look at this and say, oh, serotonin's going up. That's interesting. It's going to be a carcinoid tumor. But what's the deal with this centrally located lung mass? That means nothing to us unless we can understand that it's centrally located in the lung means that it's near the mainstem bronchi. It's not peripheral like adenocarcinoma. And so carcinoid tumors, just like small and squamous cell, usually grow centrally. So whenever you're thinking of central lung, you think carcinoid, squamous cell carcinoma, and small cell. And carcinoid tumors secrete serotonin directly into the blood. It bypasses the liver. And that leads to carcinoid syndrome. And so centrally located, plus your flushing, diarrhea, wheezing, all that stuff, plus 5-HIAA means you get a pulmonary carcinoid tumor. So on test day, flushing, wheezing, urine 5-HIAA in a central lung mass, just click carcinoid tumor, you're finished, you did it. And so it's going to have that elevated urinary 5-HIAA because that is our main metabolite. And also serotonin can cause valve fibrosis. And that's the reason we had that murmuring sound. Now I mentioned central to peripheral tumors, and those are very important. Centrally is squamous cell, small cell. And a buzzword that you can kind of think of these three is that smokers love central. So if you see hilar mass and paraneoplastic smoking, and it's squamous, small, and carcinoid. The periphery is adenocarcinoma and large cell. And so S and C, these all kind of sound like central because, that C has an S sound. So think central for CSS, and that'll really help you. Peripheral has adenocarcinoma and large cell. It doesn't sound like S at all. And so those guys would have ground glass opacity, clubbing, scarring related stuff. It's peripheral. And the only other thing to know is like your small cell. For that, you should be thinking of ACTH, SIADH, and Lambert-Eaton. Squamous cell has different associations, like parathyroid related, and for that you'd see hypercalcemia. Also keratin pearls, intracellular bridges, and smoking history. Carcinoid has, what was our answer to this question, our metabolite of serotonin. Well, adeno is most common in non-smokers, and there's a subtype called bronchoalveolar carcinoma, and that's ground glass nodules that you would see. Ground glass nodules, And then the large has undifferentiated, poor prognosis, and may present with gynecomastia or galactorrhea. So rare, paraneoplastic, that's large cell. Okay, just wanted to kind of clear up those concepts. Here are the trap answers. Alpha-fetoprotein is hepatocellular carcinoma, so different entirely. Just lock in alpha-feto with HC. PTHRP is squamous. Hypercalcemia would be seen because it's parathyroid-like. Urinary metanephrines, that's a pheochromocytoma, so episodic hypertension. Low TSH, hyperthyroidism. Okay, there's 116. Now we're going to go to 117. Here, a 15-year-old boy undergoes a serial hand and wrist x-ray during sports physical. Over the course of 2 years, his growth plates progressively ossify. Which of the following hormones most directly triggers this change? One sec, I'm going to take my dog out. Okay, my dog Charlie and I just went for a run, and we're back. Which hormone directly triggers this change? So how do bones grow in kids and teens? Now, you have long bones, like your femur, your humerus, your radius, and these all grow from the middle outward. So the long middle outward, and that's because of these zones called growth plates, the physis. And that's a layer of cartilage near the end of the long bone that allows it to grow in length. Think of this like the engine, and this runs during childhood and puberty. And what controls these guys? It's the hormones. Growth hormones from the pituitary that'll speed up the bone growth during childhood, and then testosterone and estrogen during puberty. So testosterone in the boys and estrogen in the girls increases the growth speed. But there's a twist. The testosterone turns into estrogen in the body, and that occurs via aromatase enzyme. So I'll write that right here. So estrogen closes the growth plates, and after some years of fast growth, estrogen is like, hey, physis, dude, you gotta harden, you gotta ossify. And once that cartilage turns into bone, the growth is going to stop forever. And so what you see on an x-ray in a child is you have a growth plate. That's the clear dark line at the bone end because the cartilage doesn't show up very well in the x-ray. And in the adult, you have a growth plate that disappears and leaves a white little scar line. It's a solid bone, and that means that the growth is over. So in kids, the growth plate is open, they're growing, they have growth hormone, estrogen, testosterone, but then in their teens, it closes with that's all it works. And so our answer is going to be testosterone that triggers this change. It initiates bone growth, and through aromatization to estrogen, it induces epiphyseal plate closure. That's the process. That's how it works. Other answers: aldosterone, that's in the kidneys, does not have a role in bone development. Cortisol, that contributes to your osteoclast activity, so you get bone loss, but not affecting the growth plate fusion. And parathyroid hormone is the calcium regulation via bone reabsorption. And that's unrelated to the growth plate closure. And then growth hormone stimulates it, but does not cause the closure. That's the aromatization to estrogen from testosterone. All right, time to zoom out, and we're going to 118 in our top bubble of 8. I love this infinite scroll thing. Now, this condition is one where it's important to note the demographic: 17-year-old girl with type 1 diabetes. For routine follow-up, her mother is concerned about her weight loss over the past couple of months, and the patient is unconcerned, saying she's pleased with her appearance. Okay, so what is that making you think of already? Well, to me, this makes me think of intentional underuse of insulin. That will cause weight loss and also hyperglycemia. So she's happy with the weight loss, but inside of her body, some bad things are happening. So you have elevated HbA1c, which I learned is like a monotonic indicator of all type mortality. So essentially, like the lower it is, just the better it is. And it's crazy how in medicine, we don't even really care about that. We just think, oh, you're normal. You're below like 5 point something, and so you're fine. But anyways, she's feeling fine. She's got chronic insulin omission. So she has weight loss with high HbA1c. Yep, there it is, 9%. And then that's up from 6.2. So what is the cause? It's going to be insulin underuse. Some comorbidities would be body image dissatisfaction, and other eating disorder comorbidities might be seen. The pathophysiology is that in type 1 diabetes, your body lacks insulin. And so that means glucose can't enter into the muscle and the fat cells. All right, so she's got type 1. No insulin means no glucose goes inside. Well, the cells are going to starve, and the body's going to break down fat and muscle instead. Catabolism, okay? No glucose, break down fat. Or rather, the step 3 is the insulin emission mimics that state even with food intake. And then 4, the blood glucose will rise, the HbA1c goes way up, and the glucose starts to spill into the urine. And then meanwhile, the tissues use protein and fat, and that causes weight loss and also ketone production. And then last, we have long-term risk for diabetic ketoacidosis, dehydration, and electrolyte loss. Now, a good question is why DKA? Well, DKA is life-threatening. It's insulin deficiency because you have a result of very high blood glucose and ketone production and metabolic acidosis. And so insulin is a brake on that catabolism. Insulin promotes the glucose uptake, inhibits lipolysis, so the breakdown of fat, and inhibits ketogenesis. It promotes fat and glycogen storage. And if insulin is missing or you skip it, then there's no glucose uptake. And so that the body's like, oh my gosh, I'm starving. There's no glucose. And then you start to get glucagon, which is, oh no, the glucagon is gone. And so the alpha, the glucagon is gone. And the pancreas goes, okay, we got to start doing something about that. The liver will break down fat with lipolysis. So you get free fatty acids floating around. And then the liver converts free fatty acids into ketone bodies. So think acetoacetate, beta hydroxybutyrate. And then the ketones are acidic, right? So then you have high anion gap metabolic acidosis. Meanwhile, the glucose is high. So you have osmotic diuresis. So then you have dehydration and electrolyte loss. Blood glucose is normally like above 250. And serum bicarbonate is going to be low, like less than 18 in DKA, and you'll see positive serum and urine ketones. You'll have vomiting, abdominal pain, small breathing, confusion, fruity breath. So the girl's skipping. She's skipping her shots. That causes chronic catabolism, and then that can cause acute compensation, which then triggers DKA. She's feeling fine now, but the risk is definitely going to come and get her soon through illness, infection, dehydration, and she'll just crash, right? So super important, very good to have in the back of your mind. Here's some trap answers I mentioned: celiac, bloating, chronic diarrhea, just different. Dietary restrictions, increased exercise would have like a hypoglycemia, not hyper, and then diabetic nephropathy, proteinuria, and edema. All right, there's 118. Moving on to 119. I like how they all have circles. We can dive in. Here we have a 3-month-old male evaluated for poor feeding, seizures, delayed development. Physical exam shows hypotonia, craniofacial dimorphism, hepatomegaly, and bilateral cataracts. Serum analysis shows elevated, very long chain fatty acids, and we got some acids as well, which the following findings is seen under electron microscopy of the hepatocytes. So this is Zellweger syndrome. It's a peroxisome biogenesis disorder leading to the accumulation of very long chain fatty acids. And that's a type of fatty acid that's characterized by carbon chains that have a length of 22 or more atoms. The buzzwords are hypotonia, poor feeding, hepatomegaly, craniofacial defects, and especially those very long chain fatty acids. The triad is midface hypoplasia, seizures, and early death. And so peroxisomes, they normally break down toxic fatty acids. Without them, the toxic metabolites just build up in the brain, the liver, and the other tissues. But this is associated with your PEX mutation, and that's a defective peroxisome biogenesis. So you have neurodevelopmental delay, seizures, dimorphic facial features, large frontanelles. Of course, the hallmark here is the very long-chain fatty acid buildup and also the other acids mentioned in the question. This is X-linked defect in the peroxisomal import. It's not the formation, it's the import. And the pathophysiology follows like this. It starts out where the peroxisomes are just absent. And a peroxisome, by the way, is just the small organelle that's present in the cytoplasm of many cells, and it contains the reducing enzyme catalase and also some oxidases, right? So that reducing enzyme, it ain't there. And that means they are going to accumulate. So they're going to accumulate in the CNS, the liver, the kidneys. It's toxic. And they can also impair cholesterol metabolism. So you have severe hypotonia. And hypotonia, by the way, is just low levels of muscle tone. Seizures, craniofacial abnormalities, cranial, facial. And usually they will die in infancy. So early death is seen. So they got poor tone, feeding problems, CNS problems, seizure, developmental delay, hearing loss, cataracts could be seen. And it's usually fatal. This kid's got like 3 months left to live, probably 6 to 12 months or so. There's just no peroxisomes on electron microscopy. Usually they'll be like a couple months old, maybe 2 to 4, something like that, probably 3, hypotonia, poor feeding, hepatomegaly, and then abnormal facial features. So here we have the craniofacial dimorphism, hepatomegaly, and bilateral cataracts. And so the peroxisomes, the best way to just think about this whole entire thing is that peroxisomes are like tiny detox and fat processing centers in the cells. In Zellweger syndrome, there's a genetic defect of the PEX gene, so the peroxisomes fail to form. And alpha oxidation of branched chain fatty acids fails, and the detox of hydrogen peroxide fails, and the synthesis of bile acids, like myelin-related lipids, will fail. And you might be asking, okay, well, why male models? Cataracts are the clouding of the eye lens, usually due to protein or lipid accumulation or oxidative damage. And so you get oxidative stress, right? They normally help to neutralize all those reactive oxygenating species, but without them, the oxidative stress in the lens is like super sensitive to that. We had a couple questions, I think in this practice exam, about not giving 100% oxygen to little babies because they're so sensitive to oxidative damage. And that'll lead to protein cross-linking and also clouding. Not to mention the lipid metabolite accumulation that you can see. The lipids would disrupt the lens cell homeostasis, and you have damaged structural proteins in the lens. And that causes opacification and cataracts, all the good stuff. All right, let's see these explanations. Yep, Zellweger syndrome, peroxisomal biogenesis, electron microscopy, yes, absent nuclei. Okay, so that would be impaired ribosomal synthesis. Lysosomal inclusions would be a lysosomal storage disease. That's different than your peroxisomal. And let's talk about the difference between the lysosome and the peroxisome. They're both cellular organelles, but lysosomes are responsible for breaking down and recycling cellular waste. Peroxisomes detox you. So peroxisomes, think of like the Rick and Morty episode where they get the detox going on. Megamitochondria is found in mitochondrial myopathies like MELAS, which by the way, the MELAS syndrome stands for mitochondrial and encephalomyopathy, lactic acidosis, and stroke-like episodes. You get a stroke in a kiddo, lactic acidosis, ragweed fibers, MELAS, click it. It's caused by the mutation of the tRNA, decreased oxidative phosphorylation, and then you have high energy demand problems in the brain and the muscles. So you get neuronal injury, myopathy, and lactic acidosis. Practice question, 13-year-old girl was brought to the emergency department for confusion and right-sided weakness. We have left occipital cortical lesion. Her history is short stature, sensory neural hearing loss. Serum lactate is elevated. What's the diagnosis? MELAS syndrome. Stroke-like episodes in the children are seen with hearing loss, lactic acidosis, and muscle weakness. Fabry would have angiokeratomas, alpha-galactosidase, Tay-Sachs, cherry red. Friedreich's ataxia has the GAA repeat, ataxia, scoliosis, and diabetes, not lactic. So the core problem in MELAS is that there's a mutation in mitochondrial DNA, and so the electron transport is impaired, and so you can't use oxygen efficiently, so you have to use anaerobic glycolysis, so you get lactate. And stuff like your brain and your muscles, they need that ATP, and so they're going to dump that lactic acid in the blood, and that causes problems. Lactic acid everywhere. Hopefully like that extra little practice question, and now we are on 120. Let's go, guys. If you're having a bad time, then get some weights, do some push-ups, get some dopamine going, gratitude journal. Life sucks sometimes, but remember, no thought is final. Tomorrow's going to be a new day. Find things that you're grateful for. Start a cognitive behavioral therapy notebook. You'll get through it. Dedicated period sucks, but it's also a cool time. If you're afraid of studying, that's your amygdala talking. So try to break through that. Try to say, how will I feel after I've learned some of these cool concepts? Also, I'm not judging you, man or woman. I just want you to have a good time studying. That's all I care about. With that being said, we have a 12-year-old girl with osteosarcoma undergoing chemotherapy that includes cisplatin. She experiences severe nausea shortly after her treatment. Her oncologist prescribes ondansetron. Which of the following mechanisms best explains this antiemetic effect? All right, this is a high-yield step topic. The test loves to mix and match nausea types with different receptors and drugs. It's so much fun. And so let's just build a rock-solid, kind of lesson or cheat sheet here. So there are certain types of nausea that we need to be familiar with. One is our chemo. And the involvement with their chemo, the receptors that are involved, is typically your 5-T3. That's your serotonin and also D2. And so the drug you give them is ondansetron for that effect. So for chemo, give them because it's a 5-HT3 blocker. A 5-HT3 antagonist, these are known as your cetrons. They're a class of drugs that act as a receptor antagonist, a subtype of the serotonin receptor that's found in the terminals of the vagus nerve, and also certain areas of the brain. These are antiemetics. They're used for the treatment and prevention of nausea and vomiting. They're effective in controlling nausea and vomiting produced by cancer chemotherapy, especially. And that's the gold standard for that condition. And so if you're having chemotherapy, it's going to be very sad and you're going to want to dance. I'm sorry. That's just how I remember it. Motion sickness. H1. Your histamine, also M1, your muscarinic receptor, and this one is scopolamine. And I like to think of scopolamine like you're looking through a scope of like a submarine, and so you're scoping it out, and on a submarine you get a lot of motion sickness because it's like a boat, It's just how I think about it in my brain. I'm just trying to convey what worked for me. So you're scoping out from a boat, and you have motion sickness because you're on that boat. Another one I've seen them ask about is diphenhydramine, and also meclizine too. There are also some Parkinson meds, and opioids, and these guys are typically your D2s. They affect the dopamine, and the quintessential example for that is metoclopramide. If you have like an unknown case or maybe pregnancy, that's going to be your mixed or your central and peripheral. So for that, you use pyridoxine. Maybe the test might say promethazine, but I think pyridoxine is good enough for pregnancy to know about. And then migraine stuff, you use the D2 and the 5-HT. So that's like prochlorperazine and metoclopramide can be used for that. Okay, so let's do a little bit of a recap here because this is actually pretty high yield. There's just like random facts you have to memorize, which is crazy because we have our iPhones, but that's neither here nor there. For chemo, we use blockers of 5-HT3 and D2 receptors, so ondansetron. You're sad because you have chemo, you need to dance to feel better. Motion sickness, you need to scope out as you get motion sickness on a submarine. Scopolamine. You can never be like the guy who scopes it out. You cannot be him. Scopolamine, motion sickness, can't be him. And if you didn't have this guy scoping things out, then you might die. Diphenhydramine. So that's the motion sickness little extension pack for you there, memory aid. Parkinson, D2, metoclopramide, which can also be used for your GI upset. Similarly, you could say you got the GI upset, you have to dance to feel better, but also metoclopramide because of that D2 action. You should know that it can help with the motility. Pregnancy, pyridoxine, it's kind of a mixed bag on the receptors there. And migraines use D2 and 5-HT, so metoclopramide is good. Also, prochlorperazine is used for the 5-HT and D2 class for migraine-related nausea. So not to go into much of a deep dive on these receptors, but 5-HT3 would be serotonin, so GI tract, area postrema is the location there. The D2 is in the chemoreceptor trigger zone, CTZ is what it's called, CTZ. And we say that's metoclopramide. Triggers there are like opioids, Parkinson meds, so metoclopramide, prochlorperazine also. The side effects are extrapyramidal symptoms. H1, that's your histamine. So the location is the vestibular nuclei. In case they ask about this, I'm just going to zoom in and make that clear. H1, vestibular nuclei. Motion sickness, vertigo, can't be him, diphenhydramine, meclizine, sedation, anticholinergic effects are the side effects for those guys. And your M1s, him, M, motion sickness, M for motion sickness. Scopolamine is typically a patch that you give. It can cause dry mouth and blurry vision. And I'll give you one last little bonus one because I know you guys are just having a good old time here. NK1, those are your neurokinin 1, like a prepitant that's used in combo with ondansetron and dexamethasone. It blocks substance P. And that's for delayed chemonausea. So a prepitant is the NK1. And so in the question set, if you see cisplatin, cyclophosphamide, 5-HIAA increase, stuff like that, then it's chemo-induced. And so if it's chemo-induced, what are you going to give them? Ondansetron, 5-HT3. If you see like motion sickness, they're on a cruise or a roller coaster, and they need some medication, it's going to be scopolamine. That's an M1 because of M for motion, and H for hydramine, so it's H1 as well. If you see vomiting after morphine, so that's an opioid, so it's the D2 stuff. And so metoclopramide is going to be used. That's a dopaminergic trigger. Parkinson, that's a patient with vomiting. Then you give them, maybe like a levodopa nausea. So you give them a D2 blocker, but you have to use that with caution, right? Because of those symptoms that we mentioned. And also vomiting and rigid muscles and dystonia, that's extrapyramidal symptoms from the D2 blockade. And so if that happens, they get the vomiting, the rigid stuff, switch classes. You can just use a 5-HT3 blocker instead of a D2 blocker if they have like the rigidity, because you need the dopamine to be able to move around. And if you give them a D2 blocker, well, then they're not going to be able to move around. So you just switch classes. No big deal. And a combination for regimen for chemo and nausea, preventative therapy like ondansetron is good, dexamethasone and aprepitant could be a nice solution there. All right, so muscarinic, motion sickness, scopolamine. They got the dopamine, drugs, that's like metoclopramide, and the serotonin, 5-HT3, the chemo, ondansetron. Okay, hopefully that helps. This is super high yield, super awesome if I do say so myself. I'm going to let those 10 be their own video. If you guys like this, then please consider liking and subscribing. Hopefully you guys pass this test. Take care of yourselves out there. We'll see you in the next one.